welcome to those who are joining us by live stream as well. Without any further ado, I'm going to hand over to Michelle, who will run through apologies and deputies.
Yes, we've got 5 deputies today. We've got Shane Gordon, he's deputising for Nick Hume from the Suffolk and North Essex NHS Foundation Trust. We have Nicola Park on behalf of Nico O'Shaughnessy, the Director of Children, Family and Education for Essex. Emma John from Prima Fairburn for the Social Care Providers of Suffolk. Ganesh Balia for Penny Casson from Allied Health Professionals. And Sadie Cable on behalf of Anthony Douglas from Suffolk Safeguarding Chair.
Thank you. And Michelle, could you just take us through any further declarations of interest that have been received?
So we've had a declaration of interest from Tara Spence today with regard to the maternity gender item. And just to update really from the workbook, which I know you'll go through in a minute, Andrew, since we issued the papers, we've had 38 returned. So I will go out to those that are still outstanding, and I'll take that as an action point.
Great, thank you very much. And when it comes to the workbook, I don't have it up in front of me, so I'm going to ask you to run through it, but we'll come to that in a minute. Now, there are 3 parts to the meeting today. The matters arising. There are 3 key issues for approval by the partnerships, and then there's some matters for discussion. It's quite a sort of packed timetable, so you're going to have to forgive me if I bring items to an end. I do want to make as much time for discussion as possible, but there are certain things that will need to be truncated. So please bear with me as we go through. So the first part of part 1 is the minutes from the last formal meeting on the 13th of January. For those who were there, are there any comments on the accuracy of those minutes? Well, there's a deafening silence. That's a very good sign. And so, are we all agreed that those minutes are a formal record of the meeting of the 13th of January?
Agreed.
Lots of nods.
Lots of nods. Excellent. Very good. Well, that's bought us a minute in time, so that's great. So, without any further ado, I'm going to go to the next item, which is an update from the Integrated Care Board. From Ed, and we're going to be looking at the minutes of the board meeting of the 22nd of November and an update on the meeting that was held on the 25th of January, for which there are no draft minutes at this stage. So over to you, Ed.
Thank you, Chair, and good morning, everyone. So yes, I gave an update regarding the November meeting at the last ICP session, so I won't repeat that, but you've got the minutes for you. At the meeting recently in January, we opened the meeting by paying tribute to Dame Claire Marks, who sadly passed away in November due to pancreatic cancer. Claire was the first female president of the Royal College of Surgeons and the first female chair of the GMC, and so broke glass ceilings in terms of women in leadership, which was really, really extraordinary achievements. Claire was also a consultant at Ipswich Hospital for 30 years, so gave long and distinguished service to that trust, latterly obviously as ESNEFT, and it's very fitting that the new orthopaedic centre in Colchester will be named after Dame Claire. So we just wanted to reiterate that tribute to Claire as an extraordinary person and leader and clinician. We also talked in the meeting about the importance of allied health professionals, and Ganesh, who's here today, gave an excellent presentation. We had a good discussion on that. And of course, we talked a lot about all of the hard work the system has been doing during Q3, particularly around coping with urgent and emergency care and industrial action, elective recovery, improving primary care access, a very, very long list and lots of innovative work in social care and the voluntary sector and so on. It is important, I think, I say that some of the comments in the meeting were picked up in the media regarding the state of our hospitals and went viral nationally. I know that Nick has publicly apologised for the language that he used, and I just wanted to also offer an apology as the Chief Executive of the board. What we didn't want to do was offend or insult any staff, and I know that some members of the community, some of our patients, were very alarmed by those comments, and that's the last thing we wanted to do, but that did happen. So I just wanted to offer that apology, and I think we will all consider as a board the importance of thinking carefully about the language we use in public meetings going forward. Thank you, Chair.
Well, thank you for that, Ed. And also those particular words about Claire Marks, who I had the pleasure of knowing, and as you say, was a very significant person. So excellent for that. And Mark, would you like to come in?
Yes, on Claire Marks's death, I also would like to say how much I enjoyed working with her in the time that we had together. I just wanted to follow up, Ed, about the remarks that were made within the ICB, because we had quite an animated discussion at the chairs group about the balance between the language used and the message that was being given, and how we get our messages of concern across to our public, because the message that was being given was not an incorrect one. It was just in maybe how it was dealt, and there was a lot of discussion around the context in which that message was being given. And I think on behalf of the chairs at the chairs group, there was a lot of feeling around how we have those opportunities to speak up on behalf of our workforce and the people we have in our communities, when sometimes those areas of concern actually aren't on the agendas that we have in public-facing meetings. Chairs wanted an opportunity to share that here, and consider how we do manage system messages in a more systematic and contextual way, not ducking the difficult issues that we do have, but also in how we work with our workforce and our people in our communities in order to overcome those concerns, not brush them under the carpet. Thank you.
Okay, well, thank you for that, Mark. You're still indicating that you wish to speak. If you want to take your hand down, thank you. Anybody else that wants to make any comments at this stage? No? Excellent.
Andrew?
Yes?
It's John,
John?
Andrew.
Okay, John.
I was very interested in what Mark said. There was I totally agree, Mark. We've got to be able to speak honestly with each other in places. Mark sort of took us to an extreme, using the words brushing things aside, brushing them under the carpet. What one can also get is a level of sanitization. So we're not brushing it under the carpet, but where the language is used in such a way that it takes away people's understanding of the significance. And I don't know what opportunities there are for the ICB to meet in confidential session if it just needs to have a frank conversation about that piece from time to time. I know we'd prefer to be public facing at all stages, but that mustn't get in the way of honest discussion around difficult topics.
Understood, John. Thank you for that. Can I ask, yes, Will, now, if you would like to come in, what I want to do is if you can speak to this, and then we'll move on, but it might be something you might want to consider going forward.
Yeah, thanks, Andrew, and fully agree with everything that Mark and John have just said. And just to confirm for ICP members' benefit, there definitely is an opportunity for, should we say, private conversation for the ICB and ICB members. So, and we usually take that opportunity at every meeting as required. So yes, John, the opportunity is there, and we've got to make sure we take it up in an appropriate way. So assured, therefore, I hope.
Thank you.
Okay, thank you for that. Thanks, Will. So just to move on, so the next item is the ICP workbook.
Possible. So that will be a venue to be confirmed. It's a face-to-face summit, 10 till 3 o'clock. And the idea is obviously that we're able to present the evidence-based work that's been going on within the system and start to set priorities of work to go forwards as well. And conversations with Susanna and colleagues in recent months actually is that what we don't have with the work actually is some checkpoints through the year as well. So obviously we talk about that accountability, but it'll be a good idea to obviously take stock, have a baseline of where we're at now as a system, and check through the year the maturity of that work, and then obviously build on that as we start to go forwards. We've got lots of work already going on with the system, and what we're hoping to do as well is improve the experience of students as well that come and have their practice-based learning here. So he has recently published, for example, guidance to support education of neurodivergent students. We have lots of cultural ambassadors within our system as well, and we've started to pilot a career development coach with Andre Santos, who's looking at supporting our internationally recruited AHPs and nurses within the system as well. So yes, the idea is obviously with work that we've commissioned previously with the HEIs, University of Essex have done some fantastic work there at this summit. We'll pull all of that together and start to build on that going forward. So I'll share the details with Susanna and Michelle to be circulated across this group here. And we hope to start building on this conversation and work further. That's all I have, Chair.
Okay, Ganesh, thank you for that. Yeah, so 28th of March, and there's a request to send out a hold as soon as possible for that. And I just wondered how extensive the invitations will be.
That's a great question. That's what the group are currently working on now. I mean, if this is growing, that's obviously going to dictate where we host it. We obviously want people who are currently active in this work and people, more importantly, that can lead and sponsor this work. That's where there's been the gap, Andrew, currently. So it's influencers and people who are active in that area already. Okay, good. So I've got two questions. Firstly, from Lucy Whiteman, and then from Ruth. And Nicola.
Apologies. Ganesh, we're not very good at doing this, but actually I'm going to blow ECC's trumpet because it's doing some great work around EDI. We're developing, we're just in the sort of final throes of our draft new strategy. We've had a sort of peer review process a little while ago, which was prior to me arriving, but it held quite a startling mirror up to some of our sort of practices and biases. So there's been a huge amount of work that's been undertaken, and I'll sort of particularly blow the trumpet of the adult social care team who've been undertaking a number of quests using staff that have one of our protected characteristics, for example, or one of the areas where we've had feedback where we need to be more inclusive as an employer. And they've undertaken huge amounts of work, which again has uncomfortable from a point of view of getting the feedback, but certainly from a point of view of pushing us to recognise some of the challenges our workforce and indeed our service users face day to day has been really, really refreshing. So again, if there's anything, and I know I'm kind of offering adult social care colleagues support into this, but I'm sure they would be willing to share that good practice. And indeed, we could perhaps learn from you with regard to our final draft of our EDI strategy. But I'm also just wondering, we keep kind of developing projects on an ICB or ICP basis, but this to me is a brilliant subject that could be worked on from a point of view of anchored institutions, across the piece, a much wider geography.
Apologies, Lucy. Yeah, so two things there. Rhiann and colleagues are already part of our task force, actually, so they're sharing that work, and we're well connected already. And absolutely, yes, it's the wider organisations as well. So we're looking at how, and via Sharon and David, using our sort of levers there to reach out to those organisations. So, like you say, it shouldn't just be the usual suspects. There's clearly lots of work that is being done and can be done. I know myself. Connected with Andrew and David recently around, for example, genomics, and actually with particular populations not having access to testing or not accessing that, so the inequalities there. So this will link, really well into our population health work as well. So it's connecting it up, and that's like with many things. It's this is what I'm finding. There's all this activity going on, but it's not lining up clearly for me anyway.
Okay. Thanks, Ganesh. Right, so I've got two more. Firstly, Ruth, and then Nicola, and then let's move on.
Thank you, Ganesh. It's really timely for us in the Suffolk GP Fed. We're actually looking to commission an external review to look for our culture and what it feels like to be other, and that's not simply from protected characteristics, but also not being in the in crowd and how that affects you and your ability to contribute. Obviously positively for us, actually, we want to hear from everybody, not just from the echo chamber. So, and the second part to that, which is particularly important, and I'd really like to be involved in this in a more more specifically with yourself, because I think there's other things we can learn. Is leadership. Our leadership is not diverse, and I've struggled to try and make it more diverse, and it is a struggle. So I think that's one of the really key things for us as an organisation, that people feel included. It's a place that people want to work, and that we work towards more diverse leadership to represent not only our workforce but the population.
Fair comment. Nicola, over to you.
Yeah, thank you, Chair. Really welcome this work, Ganesh, and it's something that we've struggled with as an organisation as well. There are pockets of good practice going on, but we have the same leadership challenges, representation at leadership level as Ruth has described. So it was just an offer, really, that I'd really like to be engaged in this work if possible. Obviously, you're linking with Andre Santos, which is fantastic, but we have recently relaunched our staff networks. So it's something that's very live for us. I would ask around the 28th if invites could come out as soon as possible. Really, we need a minimum of 6 weeks' notice in order to make sure that the right people can attend. So that would be great. Thank you.
Good.
Thanks,
And
Nick. Yeah.
Ganesh, you're giving some thought to that, so that's great. Thank you.
Excellent. Thank you.
Very good. Right. Thank you. Now we're moving into what we've described as part 2, which is our approvals. And we have, for the next piece, we have Fiona Ellis, who's the Chief Executive of Survivors in Transition, and being joined by Catherine Hinwood, who's the NHS England lead on domestic abuse and sexual violence, and is the Deputy Director of the Health and Justice team, and they're presenting a paper, Denial, Disbelief and Delays, examining the costs of the NHS delayed child sexual abuse disclosures in England and Wales. Now, we're being asked to approve the incorporation of the conclusions of this report into the integrated care strategy. So that is something that we will need to consider once we've heard from Fiona and Catherine. I'm going to suggest perhaps if Fiona could talk for maybe 10 to 15 minutes and Catherine for a further 5 minutes, and then we've got some time for discussion before taking a view.
Thank you, Chair, and thank you for having me here today. Before I start, I'd like to ensure that anyone affected by anything I present today can get some support, and I've put some contact details in the chat to be noted.
And can I just note, sorry to interrupt, but rather moot that this week is Sexual Abuse and Sexual Violence Awareness Week. So this is moot.
Thank you, Chair. Before I present the new report findings, I thought it'd be useful to land this in the context of previous work that we've done, which has been presented through the system previously. I hope that as I go through things today, you will start to join the dots as to why this is so important to bring here. If I could have the next slide, please. In 2015, we undertook a national survey of adult survivors of childhood sexual abuse, which challenged some of the ways that we thought and conceptualized sexual abuse, some of the things we knew, and it affirmed other things, including the following headlines, which deserve revisiting from time to time. Could I have the next slide, please? We established that sexual abuse is not typically experienced as isolated or in short-term episodes. The average duration of sexual abuse perpetrated against respondents to our survey was 7 years. In the context of the age range of childhood, this is significant, with most survivors having spent most of their childhood being sexually abused. We also drew dose-response correlations between the age of the onset of abuse and the subsequent duration of it. Over half of the respondents to our survey reported being abused by more than one person. This came as a surprise and challenged the way we view child sexual abuse as single event trauma and perpetrators' behaviour as well. The vast majority of sexual abuse goes unreported, which we know and we see in practice, at around 70%, with 90% of respondents and survivors in general never seeing their abuser brought to justice. Whilst we knew this anecdotally and has been affirmed by many reports subsequently, I'm still shocked it hasn't reframed the criminal justice system for adult survivors in the way that it should have. We established that only 11% of survivors reported that a disclosure, whether that had been successful or not, meant the end of abuse. For the majority, child sexual abuse continued for more than 6 years past this disclosure. And to note, over 30% of those who continued to be abused had disclosed to a statutory service or professional. Less than 20% of survivors had disclosed because they were asked, placing an enormous burden upon survivors to tell or to break the silence. We knew then, and we know now, that waiting to be told doesn't work. We also gained significant and important insights into the disclosure to specialist support journey. There were long, unavoidable delays between the onset of sexual abuse, the subsequent disclosure, if any, and then accessing specialist effective, often quoted as VCSE provision, with the average delay between the onset of abuse and accessing support being around 16 years. From this point onward, and loaded with lots of data and insight and understanding, we wanted to try and establish what had happened in all of those years. Could I have the next slide, please? In 2018, I worked with Emma Bond on the next phase of our research and built on what we'd uncovered in 2018. We conducted 28 in-depth life biography type interviews with survivors who had responded to the original survey. Survivors' bravery and courage gave us detail and granular insight into their individual disclosures, their journeys, and to whom, when, and what had motivated them to disclose. We established that 20% attempted to disclose in childhood and again in adulthood, whilst the majority had made their first disclosure as an adult, usually at the point of what they described as crisis, and therefore not by choice. Half of them described extremely negative responses to their disclosures, regardless of who they were to and when they happened. And we gained further insight into the 16-year delay that we'd established back in 2015. The survivors who we interviewed in depth, their narratives described a much longer timescale, on average 27 years, from the onset of abuse, potential first disclosure, and accessing effective support. All of them described in details the complexities of delayed disclosure, revealing a catalogue of missed opportunities and what started to become a familiar door of predominantly NHS-based services. And the concept of denied, disbelieved, and delayed disclosures was born. Next slide, please. It transpired through understanding their patterns and experiences that survivors generally followed a typical pattern from attempted disclosure in childhood through to specialist support. In childhood, survivors had often tried to tell but were disbelieved, dismissed, or didn't disclose at all for a range of reasons. A long time passed from the end of the abuse to the next attempted disclosure, on average about 12 years. And all but one of them made another attempted disclosure in adulthood, and many described how this had fallen on deaf ears and nothing was done. Quite often in desperation, point 4, they sought assistance from their GP, who survivors consistently reported and continue to consistently report as an important disclosure point in the system. This nearly always resulted in a referral to statutory mental health services for a raft of underlying symptoms, such as anxiety, depression, eating disorders, and self-harm. However, the underlying trauma, the sexual abuse they'd experienced, was never effectively addressed. Over a significant period of time and through accessing multiple statutory mental health provision, they recognised that they had deteriorated significantly until, in utter desperation and as a, I quote, last-ditch effort, they self-referred into a private or voluntary sector specialist service, illuminating the ineffective referral pathways and quite often poor practice within the system. I'm sure you'll agree that as a whole system, we still need to move survivors to being able to move directly from step 1 to step 7 or step 3 to step 7. There's learning here not only for the statutory sector, but for us too as a voluntary sector in terms of being more visible and more responsive. The steps in between were just largely unnecessary, ineffective, caused a lot of additional harm, re-traumatization, and were too costly on every level. If I could have the next slide. The most stark finding was that during this phase of trying to find adequate support, the survivors reported that whilst they were in receipt quite often of statutory mental health services, all but one survivor described how their general well-being had actually deteriorated, and many survivors' symptoms worsened. It was clear that they had eventually sought help from voluntary sector providers through a self-referral process. This reflects and reaffirms the findings of the survey in 2015 that survivors are more likely to find support off their own steam rather than from signposting and referral pathways. But the one thing that struck us in this was, what about those who just can't? What about those who don't have the resilience to pick up the phone or make a self-referral? Both of these reports highlighted the critical and valued part that the VCSE played in providing timely, effective and trusted support. And I believe this is the opportunity in terms of where we're at today. And there hasn't been a better time for this to happen in terms of the ICS. I remember presenting some of these findings to the STP board back in the day, and quite clearly remember Ed and a few others scratching their head and asking me, so are you telling me that we're making things worse? After some consideration and a bit of bravery, I said yes. Sadly, this is still the case today. But now we know what it's costing us. If I could have the next slide, please. On the 19th of January this year, we launched our new report with a conference in conjunction with the University of Suffolk. And we had established that the costs, both human and financial, are staggering. I'm sure you'll agree. This report provides new evidence in numbers around what we thought we knew and a new call to action for us. This is especially important considering what we're up against as a system in terms of the savings that need to be made going forward. We used a sample of the National Association of People Affected by Childhood's helpline data from 2019, where they had established that 15% of total callers to their helpline had never disclosed before, and this was the first point of disclosure. Using a discount model and some quite complex economics, with beginning at age 9 and projecting health costs forward to the point of disclosure and beyond, we established that the average lifetime cost per survivor of sexual abuse where disclosure had been delayed was estimated to be just under £5 million. We also established that the total lifetime health-related economic burden in England and Wales was estimated to be just under £3 billion annually. If I could have the next slide, please. So what we concluded, the costs to the NHS are very high, even using what we did use, which was a conservative assumption, especially in that time that I described in that roadmap of before disclosures are made, which are very often very long after the onset of sexual abuse or after the point of disclosure. Cost effectiveness and efficacy of NHS versus VCS FE interventions need to be assessed going forward. Child sexual abuse must be tackled with the same parity and efforts to tackle domestic abuse within our systems. Timely intervention and timely prevention will minimise the costs, and we don't believe that a rocket science approach needs to be applied. It's quite often moving to the next step, which is just relieving the burden of disclosure and alleviating it by asking the question and opening the door to disclosure. This must become routine in our system, and we believe that a trauma-informed approach and training for professionals would help this going forward. Next slide, please. So what we're asking that the ICP to approve today is the incorporation of the conclusions of this report into the SNE integrated care strategy. And these are specifically that the costs of CSA can be avoided and minimised through timely prevention and early intervention by working with specialist VCSE providers. I mentioned the burden of disclosure and identifying trigger points in the system effectively and looking towards a preventative model in terms of GPs, mental health, emergency and hospital staff being trained in working in trauma-informed ways. And strategies on reducing costs should include assessing the cost effectiveness of interventions offered through the NHS and or the VCSE in collaboration. Catherine Hinwood is on the call from NHS England. Catherine, if you'd like to introduce yourself and put this in the context of where we're at with regard to the work you're doing with ICSs. Thank you.
Yeah. Catherine, before you come in, would it be possible for the final slide to be left on the screen, please?
I'm going to share a couple of slides, if that's all right. Do you mind? Thank you. There's only a few of them. But before I do that, I just wanted to thank Fiona and her team so much for their outstanding work that they have done, not just in this report, but in previous reports, to really try to uncover some of the hidden impacts of child sexual abuse and really focus on the need of the healthcare system to think about those impacts and work differently. So I'm going to just put a couple of slides up that gives a little bit of context to what Fiona has just been talking about. But first of all, to introduce myself, I lead a programme of work that was commissioned by the NHS England Chief Executive early last year to think about how the NHS as a whole, but through NHS England's leadership, would be able to really try to transform the way that domestic abuse and sexual violence are considered by the system and really try to think about these crimes through a public health lens, whereas before I think we've looked at them very much through a criminal justice lens. And there's been some really fantastic work that has been done by partners and by particular locations throughout the country to... Oh, sorry, I've just put the wrong slides up. This is the kind of thing that always happens, and why I probably ought to have ensured that someone else did this. Share my screen now. Wait, there we go. There we are. This is the new strategic and legislative framework that underpins the work that my team oversees. So We've got the Domestic Abuse Act. We've heard this morning about the duty on ICBs to include the needs of victims of abuse in their joint forward plans. We've now got the serious violence duty that applies to ICBs, local authorities and the police to think about how you prevent serious violence, which now includes domestic abuse and sexual offences within its remit. You've got a duty on ICBs to collaborate in the commissioning of services to support domestic abuse, sexual violence and serious violence proposed in the new Victims Bill. And then you've got a raft of really ambitious aims in the women's health strategy about how we want to change the focus, as I said, of these crimes into a much greater public health approach, thinking about prevention. And there's a whole host of commitments here that set out the things that we'd like to focus on in the coming years through this programme. So underpinning this, some further statistics building on the ones that Fiona shared. And if you look at the crimes of domestic abuse and sexual violence and child sexual abuse as a whole, we estimate that the impact purely on the healthcare system is between 1.3 and 2 billion pounds a year, which is quite extraordinary. And when you look at the prevalence and when you look at the fact that the NHS sees 1 million patients a day, there are so many people that are going to be going through the healthcare system who have experienced domestic abuse and sexual violence that we need to be reaching. And one fact that I find quite striking and many people are not aware of is that there's been a number of studies that have shown that those working in health and social care are quite often more likely to have been victims of domestic abuse or child sexual abuse, either previously before joining or experiencing domestic abuse whilst working in the system. So I've put up here the aims of the national programme that's been put in place to try to support systems in thinking about how they can start to change the way that they focus on these crimes. So they're really quite big aims to transform the response to domestic abuse across the system, to build on safeguarding processes and think about how we can better systematise support for victims, early intervention, prevention, and address related access and health inequality issues. And one of the commitments specifically to NHS England is to show national leadership in the way we think about staff who've experienced these crimes. I shall stop sharing now. So what I wanted to offer you today was context that this report is accepted and very much part of the thinking within NHS England at the moment. So the national leadership in this space is that we should be thinking about costs and access and transforming the way that we focus on these crime types. And I think there's incredible opportunities locally to be focusing in the same way. And the discussion that I've heard here today and the way I've heard that this integrated care partnership works, I think is a really incredible opportunity to take up some of the recommendations that Fiona has made. And one of the final things I'll say is, if you do want to be more involved in the national work that I'm leading in relation to transformation of the NHS's response to domestic abuse and sexual violence, I'll pop my details in the chat. And I'd love to hear more about what you're doing or what you'd like to see done from a national perspective. Thank you.
Okay, thank you for that, Catherine, and also thank you to Fiona. It may be of interest, Catherine, we have a statistic here which I wanted to put out there, which I'm not quite sure where it's actually come from, but we're saying here that child sex abuse survivors in SNE is conservatively estimated to be 7.5% of the population. Does somebody want to speak to that before I go to those who have questions?
I'll speak to that, Chair. Thank you. That's based on Office of the National Statistics Crime Survey to 2020, I believe. So the most up-to-date prevalence data that we have in the UK at the moment.
Okay, thank you for that. I've got. I am proposing that the conclusions of this report are incorporated into the integrated care strategy. Is there anyone who disagrees with that? No? Excellent. Thank you very much for this debate and discussion around a very important topic. We're going to take a break now, and I'm going to suggest that we take a break till 10:50, so 7 minutes, if that's all right, and then we'll reconvene. Thank you.
A 5-minute break now. Are you able to attend the meeting with Lucy this afternoon?
John, this is Andy Yacoub. I'm curious about the screen backdrop to you, the forest scene. Are you aware of where it is? Is it a particular place? You're on mute. You're on mute, John. John, you're on mute. I was on mute.
Hi, Andy. I've come back into the meeting and we appear to be in a breakout room. Is that right?
Oh.
Don't worry, we're about to reconvene.
Ah, lovely. Thank you. Came back and I thought I'd missed something. Have I got time to just quickly grab a drink then?
On your own. It's all right.
That's right. You're in isolation. Okay. Just give people the benefit of another few seconds to come back in. I think we're almost all here. How many did we have before?
48.
48. Yeah. Okay, right. Let's start again then. Thank you. So we're now moving to look at the Memorandum of Understanding and Terms of Reference for the ICP, which has been updated and is for our approval. I'm going to hand over to Michelle Grant-Richardson, who's the Senior Programme Manager in the ICP, just to briefly describe what we're seeking in terms of changes to the Memorandum of Understanding in Terms of Reference. Over to you, Michelle.
Thank you, Chair. Just as a bit of background, the Suffolk and North East Essex ICP was established as part of the statutory arrangements for the ICS in July 22, and members of the ICP committee agreed that the ICP Memorandum of Understanding and the Terms of Reference should be reviewed in February 23. So they've been reviewed and we've had some minor corrections done that are recommended. You've got obviously the papers in your pack, and the sections that I'm going to refer to are actually highlighted in yellow. They are a clear indication that the MOU and terms of reference now reflect the guidance on the preparation of integrated care strategies published by the DHSC in July 22, and that's in section 2.1 of the paper. Then their clarification that the two upper tier local authority co-chairs of the ICP committee, which are Councillor John Spence and Councillor Andrew Reid, are also regarded as regular participants on the NHS ICB board, with the right to participate in meetings when and as they feel necessary. And then there's the proposed addition of a representative of the UK Health Protection Agency as a member of the ICP, and that's been reflected in the ICP members table. So as I said, they've been highlighted in yellow in the document, and the members of the ICP committee are asked to approve the new version of the MOU in terms of reference for the ICP.
Okay, thank you, Michelle. And just for clarification, and this is certainly, John, I don't know if what you feel about this, but I guess this is to give us a little bit of more flexibility around attendance of the ICB. Certainly, it's something which I would like to be able to do more often, but obviously, you and I have clashes from time to time. But do you want to comment on this at all? No, that's fine. Anybody want to make any comments around these proposed changes to the terms of reference and memorandum of understanding? Well, absolutely not. That's fine. I have one question, and maybe this is due to my naivety, but I think in this paper it was mentioned that there were planned CQC reviews for the ICS. Is that a program that's already been established, or is it something that is going to be forthcoming? Who would be able to comment on that?
Did you want me to come in on that, Andrew?
Yes, please.
As far as we understand, we did have a useful meeting. I think it was when we were still an ICS board that the CQC very kindly came along and to discuss their plans for reviews of integrated care systems. As far as I understand, those reviews are still currently in development, but there is a proposal that there will be a forward plan for reviews of ICSs, but it hasn't begun yet.
Okay, so this is something that's coming down the road towards us. I mean, the CQC is taking on a considerable amount of new work, isn't it? It's going to take some time for them to actually understand what it is that they need to do and how they're going to approach it. And
it is, but they're very clear that it would be a review of the integrated care system, right? Not to any specific partners. They take a broader review of the system in terms of the collective delivery and impact for the population.
Okay, fine. So just turning to the decision, is there anybody who is not happy for us to approve the changes to the terms of reference and memorandum? No? Perfect. That's approved. Thank you very much.
Thank you, Chair.
Right. That brings us on to the next item, and we're going to be receiving a presentation from Sharon Rohde, ICP's Senior Programme Manager, on the work surrounding the programme of Thinking Differently Together. And I believe, Sharon, you're asking us to receive this report and the outputs of all the various presentations, and to agree, like we have with the last piece around abuse, sexual abuse, for this to be incorporated into our ICS strategy. And I believe that you have taken us to page 25 of the supporting document. So over to you.
Thank you. So I'll just give a sort of verbal update because people can, look at the report. So just to summarise, we had a Thinking Differently Together event around belonging, safety and purpose, which was chaired by Dr. Will Bird, who many of us know has done a lot of work to develop those concepts and how they can help us to build and maintain resilience that helps us to manage life's challenges, including ill health and poor well-being. And we heard a lot of perspectives, including the police, young people's perspectives, the refugee, employers through the Chamber of Commerce, back to work programmes, Mind, NHS. We also heard about different ways that we can measure those concepts, ranging from the data in our JSNAs to citizens' advice data to staff surveys, because this applies obviously to everyone in whatever role they are in our system. So as you say, we've compiled that report, which is available on our website. And what we tried to do was to align that summary of the learning from the event to the two questions that our strategy has been asking. Firstly, what matters to people and why, and then how we should think differently. So drawing together those themes, regardless of the population group, people told us they want to feel safe in their own homes and in public, not just physically, but to know how to keep themselves safe, where to get help, including from health and care. They wanted welcoming spaces where they feel they belong, to get support when they need it. That could be in their communities, it could be through groups, but it could also be in those formal settings like hospitals and in care homes. People want to feel welcome at work. They want to feel free from discrimination and abuse, but they also want to feel valued for their diverse perspectives and the experience they bring. And when people feel safe, and Andrew Kelso, who's on the call here, obviously talked about this, when people feel safe, they can take risks to innovate and ultimately to improve treatment and care. And people made clear that they valued and trusted most the support from those who had lived expertise. We all want to feel understood. We know that some of our partners already do an awful lot in this around meeting those needs. But we want to ensure that everyone in health and care understands why these things are important and feels more confident to work to help people feel welcome, valued and supported. So it's around that consistency, and that's why we're talking about the strategic element of this. So we brought together that learning. We set a number of commitments in ways we want to think differently. So we want to incorporate those principles into strategy to help people feel safe by giving them the right information and creating those safe spaces. People who feel vulnerable become isolated. That impacts obviously their mental health, but also their physical health, particularly for those who are already frail. We want people to feel they belong through tackling isolation so that they can connect with family, friends and community. And we know that isolation is a particular issue for the young people, carers, older people, those with disabilities. We want people to have purpose and feel valued through work and volunteering, and enable people to fulfil their potential at work. And obviously our anchors and our workforce programs are key to this. And then we also want to measure our progress, what we do, the improvements that this means for the quality of care and support that we provide, and the improved experiences of staff and those people that we serve. So yeah, absolutely, we're requesting that the report is received and agreed in principle to those commitments. Thank you.
Thank you for that. Who would like to ask a question around this? I mean, I have a question. It's probably of one for Susanna, which is, where do we go next with this? Because we all, every part of the system has input to this. How can we take this forward? But I'll ask you to come in after Mark.
Thank you, Chair. Thank you, Sharon. The high levels of psychological safety we know are an excellent demonstration of good culture as a system, and this is what we're hearing from you and what we've heard from this event. So that people's freedom to speak up is part of the culture. It's not something you have to do through a guardian. It's the benefits we get from that are really crucial. And a bit like the child sexual abuse work that we heard from Fiona, I think adopting it into the strategy, whilst it might be the right thing to do, we have to be able to then see it reflected in the joint forward plan. How are we going to have this as a culture? How are we going to have it as a norm? How are we going to have the work around child sexual abuse reflected through what we are going to commit to do and do differently, not just adopt into a strategic document? I'd just leave it there. Thank you.
Thank you, Mark. I think that's a helpful sort of extrapolation and expansion of what I was trying to say, but you have a better understanding of the backdrop. But Susanna, can I ask you to comment?
Yes, certainly. Yeah, certainly, Chair. So Mark has indeed already made one of the points that I was going to, which is that now having incorporated this into our integrated care strategy, it's really important that we see these points reflected through not just the NHS Joint Forward Plan, but any forward plan from any partner in the system. One of the things that we need to do as an ICP is to look at kind of the impact that we're having as system partners collectively for the population. So what we're now beginning to do with some help from colleagues who are much cleverer than me with data is to weave some of those data points all the way through our strategy, which of course is a website, so it enables us to do clever techie things and to hook up points. Liesl Kennedy and John Neal presented on some of the data how can we measure things like belonging, safety and purpose in our population. and they talked about that at the event. There's that's included in the report. What I think would be really good is if we could bring this topic back to a future ICP meeting, but with some idea of a kind of dashboard type of some way that we can start to look at these ideas around belonging, safety and purpose. And I think we need to strike a balance both between across the population, but also what that means for people who are using services as well, patients and service users as well. So probably need to look at that on two levels. So I'd suggest that we should bring this back with more of a focus on how we're measuring and how we're looking at our collective impact as we go forward.
Okay, I don't mean to pin you down on this, but what sort of time frame do you think we're looking at for this keeps warm?
If I'm honest, I mean, to get this right and to have an opportunity for those two things to work their way through, the planning stuff and also the measures, I'd say about 6 months' time. So maybe about the autumn this year. Okay,
thank you. Can we put that down as a marker and see where we go and review that in 3 months or so, just to see, if we're on track. Any further questions for Sharon and Susanna on this one? Stuart.
I was just sorry, problems with sound again. Just reflecting on the point and the conversation about the JFP earlier, and so that Mark made the point around, and the JFP being for about where that sits across and us as an ICP versus the ICB in that. And I suppose we were talking about, and we've talked about prioritisation when we were talking about the strategy. And I suppose what dawns on me is we can have 10 priorities within kind of the ICB joint forward plan, but it comes back to, again, so we've talked today about the importance of sexual abuse and some of those things about what system can get hold of. And I suppose it brings me back to, are there some actions that we as an ICP could commit to more widely? Because I just feel like some of the stuff within the ICB, the top 10, is going to have to be some of the business as usual stuff because it needs to be in there. But fundamentally, I think we need to monitor, but is there something about a commitment of 4 or 5 things at the ICP that we could do together? And that's the bit that I think I'm struggling with, because I think if not, is there something we can all feed into? So it's just to put that thought out there and to get that balance between saying that things aren't more important than each other, but actually there are some things that we have limited resource. What could we collectively all push into and lean into over the next year or so?
Okay, Susanna.
Absolutely agree, Stuart. I mean, we talked about sort of 2 levels. We talked about having a kind of prioritisation tool or something like that, just generally for day-to-day work. How do you pick a priority day-to-day? But there's something about where we're agreeing joint action across partners. So that might need us to understand not just the NHS planning round, which Richard's been taking us through and taking us on the journey of, but also where are there opportunities to make some commitments around other sort of planning rounds as well. So it'd be really good perhaps if we could sit down and kind of understand kind of the local authority ones, how do you plan priorities for public health or social care, those sorts of things as well. So we can start to think about where we might be able to draw some of those processes together and make some collective commitments across the system.
Okay, yeah, that sounds sensible. Richard, then Sharon.
Absolutely agree with that, Stuart. And I think there's an opportunity with the feedback we're getting through both the process we've had in the ICP and then the process to get to the 10. There's things already coming out that I think are better placed as a system commitment rather than an ICB commitment. And actually, there's clearly synergy between them. So I think there's a good opportunity over the next few months as we finalise the JFP to also do what you've just described through whatever exercise to say, these are the ones that the ICB are committed to. There may be an overlap with then the top X number of priorities that the ICP commit to. And Sharon's already doing a brilliant job of starting to articulate some of those into the JFP, of which, again, some of them could be ICP ones.
Okay, that's good. Sharon, you want to come in and then I want to make a suggestion.
Yeah, just really briefly, I think absolutely agree with everything everyone said. I think I think the point is that there is good stuff going on. You know, I know Essex County Council have done training, for example, we were talking about child sexual abuse on trauma-informed practice for their social workers. I know Suffolk have done similar things as well. There's pockets of stuff out there. I think part of this process around joint commitments is learning from each other and what each other's already doing. Well, we don't have to reinvent the wheel with a lot of this stuff. It's just picking up what's best and what works.
Yeah, I thoroughly understand that, Sharon. Stuart, you want to come in and then we'll move on.
I agree that, but I think the other bit is not just about amplifying. So I think there's something about learning from each other, but saying that these are the 3 or 4 things that we will lean into more broadly, because I think that's where we get the additionality of us coming together within that, I think.
Okay. Fine, thank you for that. I think that what I'm going to suggest is that we do incorporate this within our plans strategy, but that I'm going to suggest that Stuart, Richard, and Susanna get together and decide how best to move this into making things happen around the idea of a handful of things to focus on. Are you happy with that? Excellent. I see a thumbs up. Is everybody happy with this? Is anybody unhappy that we should take that approach? No? Then thus approved. Thank you very much. So we're now moving into part 3 of our agenda, where we've got a number of items for discussion. And the first one is with Ed Garrett, obviously Chief Executive of the ICB, and to talk us through the NHS England delivery plan for recovery, urgent and emergency care services. And I know, John Spence, you want to come in on this point. So I'm writing you down for the first question. But over to you, Ed.
Thank you, Andrew. So perhaps we'll do this as a medley of an Englishman and 2 Scotsmen. So if I start just to introduce what's in the plan, I'm sure you'll have read it in detail, but just to summarise that, Andrew will then do something more important, which is talking a little bit about the improvement work we're now doing around UEC. And I think there's some fantastic work underway in SNE and gives us a lot of optimism around improvement. And then, as you said, Chair, John wanted to reframe, I think, some of the discussion and the context around social care in a way that I think we would all support. So if I could start, so that there's been a national plan on urgent emergency care published by NHS England due to the severe safety concerns that I think we would all see. The ambition in the plan is to deliver 76% performance in emergency departments, 4-hour performance by March 2024, which is a long way from the 95% standard we used to work to, and that Category 2 ambulance responses should deliver a 30-minute average in the next financial year. It's currently running at about an hour's average. This is for people, for example, who've had a stroke. The 5 elements of the plan is to increase capacity in the health service, given that 19 out of 20 beds are currently occupied. Increase workforce size, given that almost 12%, there's a 12% vacancy rate in the NHS and a 9% sickness rate. So looking at those measures as well as increasing capacity, particularly in terms of ambulance paramedics. Improved discharge, in that currently the plan says that there's any one time at least 14,000 beds occupied in England by patients ready to leave. Fourthly, expand care outside of hospital, given that 20% of emergency admissions could be avoided if we had a more joined up approach to admission prevention. And then finally, making it easier to access care. And the plan particularly talks about promoting the use of 111. So that's the shape of the national plan. Perhaps, Andrew, do you want to talk a little bit about the work we've been doing with ESIST and the community hub model that's emerging or has emerged and was supported yesterday at our SOAC, and then we'll invite John to talk from a social care perspective. So over to you, Andrew.
Yeah, thanks, Ed. So ESIST stands for Emergency Care Improvement Support Team. It's part of NHS England, but it works across the whole emergency care pathway, and they usually work directly with providers and occasionally directly with regions, but until recently they hadn't worked with systems. So we're exploring new territory, trying to work out how we might work with ESIST to improve the performance and the access to emergency care for our people. When I look at the problems we've got with emergency care, I think there are 4 things we can do to change our system to make it work better. The first of them is that there is a health and care professional leader-shaped hole in the middle of our improvement work in urgent and emergency care, and I think we can create and promote and support much more health and care professional leadership in this space. And given that health and care professionals are the people actually delivering the service, they're the ones that should be telling us exactly how we should be improving it and where the opportunities lie. So there is huge scope to change our course by using our health and care professionals more closely. I think we also, and I've got some agreement from colleagues, I think we also need to look much more methodically at how we improve. We're very good at doing some fairly traditional NHSE type projects, and I think you all know what I mean when I say that. But actually, I think we can look to improvement science to sharpen our game, and we should do that across the system. I think we need to consider what we mean by executive and senior management sponsorship and engagement, because all the work seems to suggest that that is an important factor for driving improvement to the urgent emergency care pathway. So we could spend some time looking at that. And then finally, we have to look across the system at how we provide transformational support to all the people that want to make those improvements. So hopefully ESIST can help us to do that. And there are 2 big projects that we want to start with. One of them is to look at some learnings from a national study where they've looked at the 10 best performing trusts in the country with respect to ambulance handover times and worked out what were the things that were good about those trusts, why did it work so well. So we want to try and implement some of the learning from that. And the second thing is to adopt a concept called the system grand rounds, where we do a peer review process of all patients on medical pathways in our hospitals, looking at why they're in hospital and what we could do to improve that situation. But more crucially, taking the learning from that out and using it to affect future work rather than just affecting the performance on the day. There's one important concept I think I'd like to discuss with you today as this group, which is that we need to start viewing the urgent and emergency care pathway truly end to end. It starts in a patient's home and it finishes in a patient's home. We always focus on the front door of hospitals, but actually what happens to the patient at home before they become unwell and what happens to them at home after the discharge from hospital is crucially important to determining how that pathway works. And we don't often put enough emphasis on that. So working closely with colleagues from the county councils particularly will be really helpful in that, and as well as the voluntary sector as well. Another big development that should help us manage the flow of patients through the urgent emergency care pathway is this concept of a community hub, which is one common pathway where all patients who require escalation of their care in some shape or form are referred into, and we have knowledge of and refer to all possible options rather than taking them directly to the emergency department. That may include admitting them to a virtual ward. It may include a community team going to their home. It may include a mental health referral. It may include some voluntary sector support. There are many, many ways in which we could improve that bit of the pathway. And that's being led by Neil Maloney, who's the Managing Director at ESNEFT, in collaboration with system partners. And again, working closely with ESIS, we'd hope to implement that and expand on that as we develop this work.
Okay, thank you. Before I come to you, John, I've just note that Ruth and then Mark Chenton want to come in. So, John.
Well, thank you, Andrew, and apologies that earlier I had a bit of a technology failure for 10 minutes and I missed something which I'll come back to on separately. And Ed, thanks for describing an Englishman and two Scots as a medley. I might prefer to be a rich alliance, being a strong unionist myself. But Ed, on one point you made, you just did say about 111, encouraging usage. Encouraging usage of 111 will work better if 111 can avoid being an A&E referral service, which the anecdotal feedback I get from here is where it's in danger of becoming. Andrew, your points were very well made. And I like the concept of the community hub. I just guard against the word of saying that for all, still using the word patients, for all residents needing escalation, clearly it is in appropriate cases. My concern, Andrew, in just asking to say something, was I worried that some of you might not have seen the joint LGA letter that was sent to the Secretary of State, giving the views of local government. We're making many points, not all of which I agree in detail, but I think it's just important we hear what other parts of the system are saying, and maybe Susanna, one of the team, could just circulate that letter round to the people who are unlikely to have seen it. What I like about it is it puts a very clear piece there about avoiding obfuscation or the clouding of who's responsible for what. And there was a sense in some of the stuff that went on before Christmas with the Downing Street and the outcomes of the Downing Street meeting, but interestingly, it was about health and social care, but basically it was NHS that were there. It just led to some worries about that. I think we're overcoming that superbly, Andrew. I'm very grateful for the work that's been done, led by Ed and his colleagues, to try to make sure we operate to one version of the truth across Essex and that we don't have silly disagreements about data. Because what's so important, as I observe, that while across our three systems, hospital delayed discharges are relatively few in number, so thank you. Actually, once somebody is delayed, they seem to be delayed quite a long time. And the more we can work on getting those pathways that Andrew was describing working really well to you minimise the delays, which I think we're quite strong at across the systems, but B, then you minimise the length of the delay. And that's where I think we've got some real opportunities still, Andrew.
Thank you, John, and I agree with you. I've got Ruth, Mark Shenton, Judy, and then Shane Gordon, and then Nicola Cottington.
Okay, I could talk on this for quite a long time, but I think it's really important that we take that we are able to have a local version of this. I mean, how we will deliver 111 clinical staff, paramedics, EMTs, no mention of primary care in there. When you talk about the patient leave, the journey being from when they leave their home to when they come back to their home, there may have already been contact with a district nurse, a hospice, a GP, a carer in the home, who will all be having conversations with who may be having conversations with ambulance colleagues, which then may hand off into myself and my colleagues working in ED streaming. And I think one of the difficulties I've had this winter is that a lot of conversations have been had, including from the, is it USIS? Sorry, apologies, about what we should do, not taking into account what we're already doing. So, we could do this in streaming and we could do that and move those patients around. Actually, those conversations were already happening with primary care and ED colleagues in a really joined up collaborative way with some really interesting and innovative ways of doing that. And key to that is when we're looking at pathways going through that, and apologies, this is Ipswich and West Suffolk particularly, but when we're looking at pathways in that space, it's about trying to make the best use, the easiest and the most simple patient journey through that, and reaching up into the hospital, but back out into primary care, so that everybody, that we're not just designing something which is in isolation. And I think that's my point. Sometimes things are designed and it says blah blah blah, and then go to ED with not any consultation or consideration about what will happen when somebody gets to ED, and is that the actual right place? So I absolutely welcome this. I completely, and sorry, I am focused on health again, and I do totally appreciate the other parts that have been touched upon. Thank you, Councillor Spence and Andrew. But I think we need to have the right people in those conversations, and actually to be clear that things are joined up, that we're not inventing things that actually are already being developed in parallel.
That's fair. That's fair enough. Okay, so I've got 6 further people who wish to speak, and then I'm going to move on. First, Mark Shenton, Judy Newman, Shane Gordon, Nicola Cottington, Kirsten Alderson, and then Peter Smythe. Over to you, Mark.
Okay, so first thing is lowering what was a quality standard to now what is clearly a process standard, something that we should be ambitious about, saying, we should be standing up for the quality of what we're doing, not just saying that we achieve a process standard. What's happening to our golden hours for patients with stroke and heart attacks. If you don't happen to have your stroke between 9 and 11 in the morning, Monday to Friday in East Suffolk, you won't be able to get a thrombectomy because the whole of the system will not facilitate that for you, I'm afraid. And there's the question that Chair's raised around how we get together collectively as a system, but also with our population about how we can prepare for predictable times of surge in need in the future, both in the context of our ageing population, but also in the fact that our populations are becoming more deprived. We are going to have much bigger challenges as we go forward. And I just want to make a big pitch that this is about relationships and conversations between people who are in need and their professionals who are there to support them, and also about the ability of professionals to speak to each other in a timely way about the needs of those people that they're caring for, not just about referrals. And how we can support those conversations. We saw in the early days of COVID, keeping those communication channels open and timely were ways in which we could head off a lot of that need without the process of referral and moving people around the system, but more us moving around them. Thank you.
Thank you, Mark. Right, Judy.
Thank you. Yes, hugely supportive of this, and just very keen really to weave in the work of the ICS End of Life group, who are doing a huge amount, Karen Shumley and others, around early identification of those that are deemed to be in the last year of life, the Respect rollout that's going to be launched on the 1st of March, more ACP planning. I mean, there's a huge amount of effort that's going on in this space that absolutely will help with this, because as we all know, the vast majority of hospice care is delivered in people's homes. It's not only helping with discharge, but it's helping avoid those admissions in the first place. And I'd be really keen that we lean in and learn the lessons from what we're already doing, because as you know, in the first stages of a hospice and ESNEFT in the East, for example, are co-funding the virtual ward problem. And one of the things that you'll really see across the country is that when systems get very, very busy, hospice referrals often drop. So it's understanding what, even though you can have fantastic pathways there, understanding the very human barriers that sometimes kick in when people just get really, really busy. Now, there's ways of overcoming that, and we are overcoming them. But I think we just need to weave this in, Andrew, and make sure that we don't lose some fantastic work that is underway with Karen and others. Thank you.
Thank you, Judy. Shane Gordon. Hello.
Thank you, Chairman. So I agree. This is such an important area of focus, and at the moment, unfortunately, some of the initial conversation at the beginning of Ed's introduction around the comments that were made at the last ICB actually apply really strongly in urgent emergency care at the moment. We are not anywhere near where we need to be for the people that we're trying to serve, and the experience and the outcomes of care that we're able to deliver for people are far from where we want to be. So it's really welcome to have this focus on the urgent emergency care for our most vulnerable residents. Andrew, I think all the areas of focus you've identified are important. There are a couple that you didn't mention that are in the guidance that's included in the papers. So one that stands out is ambulance conveyance. So the rate of conveyance by East of England Ambulance is now amongst the highest in the country. And there are big opportunities there for us. So we're conveying 56% of ambulance call-outs to hospital. In one of the other regions in the south, that's down to 35%. So we've got a long way to go to be as efficient as that in stopping people getting in the wrong place in the first place. I think we have to recognise the complexity of the patients that are coming through. So colleagues in primary care have alluded to that. We've got very good data in the hospitals showing a vast increase in the comorbidity of patients coming into the hospitals. They are much sicker than they were pre-pandemic, and some of that is the interruption of care. Some of it is the economic challenges that people are facing. Some of it is the ageing of the population. But we've got to recognise that change in complexity. That has a knock-on effect and length of stay. And I think it's really important, as Councillor Spence said, not to get into a blame game with our partners in the system about why we're struggling to get people out of hospital. We're struggling for a whole myriad of reasons, and we need to work together to solve those. But there is the first part of the new guidance is really clear. We need more beds in hospitals, and it's something we've worked really hard not to have to do for many, many years. But the East of England has just about the lowest number of beds in England of any region. SNE has a lower average even than that in the number of acute hospital beds per head of population, and that's accounting for some of that poor experience of care. So we've got Colchester running effectively at 120% bed occupancy for the last 3 months, Ipswich at 105%, and the safe level is 92%. And we wonder why we've got bad experience and bad outcomes. So there's a few bits in there I'd just encourage you not to lose sight of in all the good work we're doing in the community space. Thank you.
Thank you for that, Shane. And just to note that we've got the summit, or system summit, coming up in April, which is being coordinated by Susanna and her team in the ICP. And I think this is a very helpful precursor to that in terms of identifying the key issues. Andy, I'm going to add you to the list, but you are definitely the last one because we need to move to other things. So over to Nicola.
Thank you. What a popular topic. I similarly could talk about this at length, so I'll try and limit my contribution. It's very close to my heart and my day-to-day work. So I also attended a Winter Collaborative event yesterday, and thankfully the focus was much wider than just the emergency department, which I think is really helpful. But I would echo Ruth's concerns about the workforce element and our need to localise this and make this make sense for us locally. Absolutely a focus on 111 staffing and paramedics, but actually in order to staff that additional acute bedded capacity, we will need more nurses, more doctors, etc. And I haven't seen a plan that sits underneath this for that part of the workforce. So I think we do need to focus on that. Similarly, kind of thinking about 111 dispositions, I think that there is still some communication work to do with our population around this. So we welcomed ESIS to West Suffolk a couple of weeks ago, and they shared some really useful data with us that from 111, only 9% of 111 callers are advised to attend A&E, but 35% actually attend there after calling 111. So people are making their own decisions for lots of reasons. But I think we need to try and understand some of this information together so that we can kind of work on the solutions. And I absolutely agree with Shane's point about acute bedded capacity. But it also strikes us, so we need to do both, don't we? We need to invest in community as well as acute, recognising that that there's still that high proportion of patients. I think about 13% of patients actually who are in an acute bed who don't need to be there. So in a way, expanding acute bed capacity just accepts that as a norm, and it shouldn't be a norm because it does create harm for people. So it's about doing both, I think.
Okay, thank you, Nicola. I'll just say that the letter that's been referred to, the link has been put into chat. Kirsten Alderson, Peter Smythe, and then finally Andy Yaku.
Thank you, Chair. I am supportive of this. I just thought it would be remiss not to mention the impact on families and family carers. Family carers are a very large and often forgotten workforce in health and social care, and there will be an impact on them. So I just think we need to bear that in mind. Thank you.
Thank you for that. Peter?
Yeah, I do want to also join the heresy that more hospital beds should be welcomed. So that's I think that's sensible. My question is how that flows through to our local planning. So in particular, the future systems program work that's going on in the West. I think we should acknowledge the 5,000 beds and stick that in our model, because the current projections make me feel quite nervous. Primary care strategy is missing. It's explicitly acknowledged in the last slide. And I think that's probably an oversight, because when we talk about community hubs, intrinsic to that is community medical support, and that used to be called your local surgery. And I think that's important because when you operate in a county that's relatively rural, it's very difficult to operationalize community hubs that stand up and do exactly what you want them to do without using existing infrastructure. So I think the primary care strategy is a serious omission. And then just a word of support for localizing 111. It is undoubtedly the case that 111 produces bizarre outcomes repeatedly, and the more local ownership we can have of 111, the better outcomes we can have for the whole system. There's a great example on page 40 of how a system has started to do that, and I think we'd do well to follow.
Thank you, Peter. Andy, and then we're going to the next topic.
Thank you, Chair. I'm struggling to think about how I'm going to word this. I'll start by saying the effort has been phenomenal, seriously phenomenal, this past winter, or the latter end of this winter. And I completely recognise that the efforts in trying to approach this huge challenge in an integrated way, in a joined up way. But I think there are some fundamentals that we could still try and address in some way. And it's related with GDPR and knowing who the patients are, either before they end up in hospital. So they will be known to our GPs, for instance, our pharmacists, and some of the voluntary community sector. And then, of course, they'll be known to others once they leave hospital, either going home or to a care home. What we struggle with is knowing who these people are. So if you are an individual and you've left